Her, she's also founder of Baby Shastra. I'm sorry, I forgot that. She's a founder of Baby Shastra, where she helps parents online. And that is where her commitment to professional excellence comes. And it is her community service, and that has established her as a very respected leader in the field of neonatal therapy and early intervention in Pune. And I also know that she regularly contributes articles in the Pune Mirror, that is the newspaper, where she provides information to young parents, about what to do and with their child. So here is to you, Dr. Puja.
Thank you. Thank you. It feels like you're talking about someone else.
No, and one more thing, Dr. Puja has been a student of Dr. Suzanne Campbell, the author of so many pediatric physiotherapy books in the
Yes.
US. So,
Yes.
that itself is a great distinguishing, position. I would, to be a student of Suzanne Campbell is not a small feat. Okay.
They
So,
were some of the greatest years of my life, for sure,
yes,
professionally.
yes, yes.
Thank you. Thank you so much for those kind words. Today, my topic is developmental monitoring of high-risk infants in the first year. Um, like Ushma just very kindly talked about, for the last 24 years, I have mainly worked in early intervention, so that's the 0 to 3 years, and then moving backwards into the NICU. So I come, from that perspective as a clinician in this realm for so many years. But oops. Today, I would like to, just talk about what are the complexities of monitoring in these high-risk infants and what role do we play as therapists. Quickly, I will just, because we may be a diverse audience, so I just wanted to make sure we're all on the same page about a few things. Um, High risk infants are basically classified, or the risk classification of these can be based on the gestational age, the weight at birth, some of the health conditions that occur at birth, or a pre existing condition. And in terms of monitoring, these are the words that are very commonly used: surveillance, screening, and assessment. I would like to add one word to this, group, which is called anticipatory guidance, which is where I have primarily moved towards now. Um, this is an algorithm that has come up. I mean, there are many, they've been out, I think, since almost 2000, 2002. A lot of these have been, published by many countries, by many professional organizations. We also have a recent Indian publication from IAP. I just like this module, the visual of this, so I've put this up. But this just goes through the how they categorize risk and what are the risk of the conditions that are associated with some of these factors. Again, a quick algorithm, very, very frequently used again for the last 20, 24 years, since this process of surveillance and screening and monitoring has been regulated, or it's being, it's coming to this point where we have, some of these protocols and processes in place. So basically, the fundamentals are that every well baby visit is when you provide surveillance. There are certain recommended ages for when you use a screening tool. If your surveillance or your screening tool provides you with information that you need further assessment, definitely they go to a, in India, we do have developmental pediatricians. In some countries, you can directly go to the therapist, for a formal assessment. If everything is well, you just schedule the next visit, or if you're sort of not sure, instead of waiting for another 3 or 6 months, depending on when the vaccination visit is, you can invite the parents a little early to come see you and discuss some of the concerns or some of the things that you might be looking at today. This is a simple process of referrals. Again, like we talked about, if the surveillance, if everything is fine on surveillance, if your screening, is negative, then you will provide what I term, like I said, anticipatory guidance, which is basically, again, we'll talk about it in a little detail as we go along, but we are basically trying to provide information to the parents so that the next milestone is on track. If there are some deviations, for example, the baby is, say, not where you want them to be, you can provide them with some home program, some mainly interaction, modifications, engagement modifications, or environmental modifications, and then call them back in 2 or 3 weeks or a month, depending on how far or close they live, and then just, monitor again if they have caught up. So if they've gone back to the, regular typical development track, or if they've gone further into the delay process. Sometimes it's very easy to pick up a frank delay, and we immediately then get a referral for these babies very early on. Some of the complexities, like I said, of the NICU graduates, I feel like, we all might be associated with an NICU, walking into an NICU on a referral basis, maybe. And our units are kind of set up, to cater to the community that they are serving. And so we don't really have a very uniform, protocol in that sense, even in India, within India, because we are so diverse. When I talk to, other therapists, I feel like coming from a very urban place, I, feel a little more privileged in terms of the access, to various professionals. Like, we have a speech therapist, we have a psychologist, we have this, we have that, we have social workers, we have, a bigger team, versus a lot of times there is only one therapist that is sort of, taking care of a lot of these things. So not only is the sort of the complexity within the process of that, or the development of that child, but where, the environment or the provision of services are. So in terms of, our NICU grads who are leaving, transitioning to go home, the first thing to remember is safety or safe space. As we all know that, for us to, like, basically learn and process anything, if you are in a heightened state of panic or fear, if your fight or flight is triggered all the time, if you're at that high stress level, at all times, you don't know where the next, disturbance is coming from. You don't know how you're going to regulate yourself if that happens. All of these sort of things that are very rampant in an NICU situation. That is what the child has learned, the baby has learned from day one. And so going home is basically transitioning that infant to that safe space 24/7. In the NICUs, a lot of times mothers or parents will come in for kangaroo care or breastfeeding or reading to their infants, or learning to diaper and swaddle and all of these things as they get closer to discharge. But even then, it is a little bit of a come and go situation. It's only when the baby is given to the mother, 24/7, either they are roomed in a step down unit or they are discharged directly home. That is where, that safety is then a fundamental thing for that child, right? It's there 24/7. This parent, that they have known throughout the pregnancy, is now available to them 24/7. On the flip side, if you look at, what the parent is feeling, the parent is feeling a lot of fear, a lot of worry, because no one has really ever thought of, an NICU as an experience or an outcome or an end to their pregnancy. We are all sort of very positive and focused on, the happy, healthy delivery process, the baby, being term baby, the sort of the chubby, pink, happy sort of, that those kind of experiences. And then suddenly this is a very unexpected situation where either, the maternal health is at risk or the fetal health is at risk, which is why they end up with a preterm delivery. And then you don't know what is happening because there is a physical separation, or oftentimes these babies go to the NICU and the mothers or the families are outside, those four walls, and so they have no idea what's happening in there. They only know what information comes out via the, medical team. A lot of times the anxiety is so high that even when you're explaining, even if when the team is explaining what they are doing with their babies, I don't think it registers, enough. So there's a lot of that heightened anxiety even with the families, with the parent, with the mother. And so when we talk about co-regulation, if the parent is not calm and composed, then the infant is not able to get to that calm and safe space as well. Um, Going home, there's a lot of overprotectiveness sometimes where, they feel like the baby has gone through so much. And now you're asking me to, place the baby in tummy time, or you're asking me to do all these things with my infant, which are a little scary to me because I'm not very confident holding a very tiny baby that I have seen with tubes and wires and beeps on the machine, that keep fluctuating, things like that. So the mother and the parents are basically feeling a little more overprotective of this infant. There is also a lot of guilt. Never underestimate the power of guilt in mothers, especially. We were just talking about this one mother that we were trying to help with breastfeeding, and they're doing very well. The baby's doing well. They're getting closer to discharge. They've been in the unit for a while. They've been given a lot of assistance with lactation, and still they're not able to get the required amount of breast milk. And so we were just talking about what else can we be missing in this situation, right? From our perspective, we are providing that medical care totally. And so we talked about maybe family support. And then there was a conversation with the father, with the grandparent, and we realized that they seem to be very sensible, very reasonable. Doesn't feel like there is a lot of that lack of positive support in the family. And then we kind of were like, well, maybe this mother is just feeling guilty about the whole process, that she's not able to feed her child because obviously she can see that the milk supply is not enough. We are supplementing that. And so we kind of had then a word with her saying that, what, your baby's not starving. We have other alternatives. We have donor milk. And, if that is not available, we can move to formula. Whatever milk that you are providing your child is good. It is, providing them with the immunity factors that they need, all the healthy nutrition that they need. And so something is better than nothing. And we are not letting your baby's health be in jeopardy, right? And sure enough, 2 days later, guess what happens? She has a better milk supply. They do go home on a combination feed, but my point is that never underestimate the parents' mental health when you're talking to an NICU family. So this, like I said, the standard rules of parenting really don't apply, to these families or the mother, I mean the baby and the family. Um, so the other thing that I find very interesting is the regulation and the co-regulation piece that we were just talking about. I believe that like we really don't have that space for the parent either, to get into that calm space. Some parents like to be given just quiet time. Some parents like to be provided more information. Some parents want, just enough information about what do I do with my baby right now. Like, don't talk about why this happened, why prone is good, or why, the posture matters, or why, I need to sort of touch my baby, with a firm hand. They don't want to know all that. They just want to know, tell me what I need to do and how do I do that. And so our job also as therapists becomes a little bit of like Sherlock Holmes. You have to find out what, the parents needs are in that sense. And that is where we then start building up, not just the baby needs, but the parent needs as well. There's a little bit of, like I said, lack of awareness about what the NICU environment is. Um, in general, there is a lack of what child development is. There are a lot of Indian publications that talk about how parents are not really aware of when the milestones should occur. The level of knowledge about child development overall is a little bit lacking in the Indian context. And so I feel like that is another complexity that we have to deal with, because here you are, trying to send them home. And one of the first sort of, um, how should I say that? One of the first things that kind of will help you identify a delay is actually a parent saying that, oh, I don't think my child is doing this, as often as they need to, or equally on both sides, or whatever it is, right? And so if your families are not really observing, how the child is moving, talking, walking, engaging, all of these things, we are really struggling in that sense. Even like I said, they come to us at 2 months. If I say, hey, I don't see the baby move their head as much as I would like to, there's a little bit of, we can, they don't need to hold their head up till 6 months or something like that. And so awareness of, the milestones really does impact us more than, the typical PNC babies would. Um, I feel like I kind of didn't go through the sequence properly, but let me just go back and look at this. Little bit of this dance was of between expectation and reality. Again, preterm infants, we know we adjust their age to check for development. So we are not expecting them to have development according to their chronological age. And this really impacts, the 30 weeker, the 31 weeker, but also the 36 weeker, right? Because not only they might look a little bigger, or they might look like they don't really require a lot of assistance. Some of these babies might not even come into the NICU, right? At birth, if they're breathing very well, they might not be admitted to a NICU. They might just be observed in a PNC unit for a couple extra days and sent home. But we know that their, lung capacity is not really operational, or the alveolar stage, it doesn't begin till 37 weeks and goes up to 8 years. And so you might see a lot of these babies have feeding issues. A lot of these babies have sort of sleep regulation, those kind of issues, which sometimes can kind of fall under the behavior, and parents might just ignore it. But these are things that actually do impact, or the late preterms, um, or the early term babies. These are some of the things that, I mean, they are a reality for them. And simply because they look older, or they haven't had an NICU stay, they haven't required oxygen support or any of these things, a lot of times, we forget that we are maybe expecting a little more than what they are capable of. Um, Eat, sleep, poop, right? That's what we know babies will do. If you ask a mother, during her pregnancy, what do you expect babies do? Mostly this is the answer, right? They eat, they poop, they go to sleep. And then maybe, in a few months, they will start engaging with the family around. But again, they are not expected to do a lot of these things till term age. Now here they are, preterm infants or um, uh, you know, with what do you say, with some kind of health issue that doesn't allow some of these, systems to naturally progress into real life in that sense, right? So, for example, babies are eating in utero as well, but how much energy is being used in utero versus when they are trying to eat like by themselves, feed, digest, so feed and control their breathing, digest that food, and then use that, for their movements and growth and all of these things. So there's a lot of additional energy burden that is, on this little human, and it's very easy for them to sort of tip over, into that um, weight loss, or they kind of be sad, and then they kind of, or they plateau a little bit for a few days, they are, say, 2 days they've been on an upward trend, and then suddenly they plateau for 2 3 days, and then they'll go back, or they'll be back and forth as well. They'll drop down and go back up again. So there's a lot of this that is happening, and it adds on to this again, leading to how this parent is now perceiving their role as a parent. If it is their first child, it is harder because they have had no experience with how a typical newborn, 2 or 3 months, uh, sort of that time passes. And so their whole experience of dealing with a newborn is this, right? High stress level, high anxiety level, uncertainty. You don't know what's coming, and there's a constant level of that. Like I said, the fight or flight is constantly active. So not just again the infant, but the parent as well. And so if this is the environment in which this parent is supposed to now learn how to parent, it becomes harder for them to trust their own instinct, right? So a lot of times I will, I'm walking by, the baby is sort of upset, crying, whatever, and the mother's just kind of like, okay, what do I do? What do I do? And I'll be like, your baby is crying, why don't you just grab the baby? Let's see what, sometimes they just need you. You don't know. Oh, no, no, wait, I need to, set this up, set that up. And so I feel like there's a lot of that anxiety that hampers their ability to look at their own instinct, to trust their own instinct, and to trust that they can take care of their child, in a great manner. Um, and so some of these cycles are, indicative of how the baby is doing and how the parent is responding to that infant. Um, okay, so in terms of the well baby visits and the access to community services, I think that is another complexity that we have to deal with. A lot of times, like I work in a tertiary care setup, both the hospitals are tertiary care setups, so we don't really once the families get discharged, our follow-up rate is very low because they end up going to their local pediatricians or their primary healthcare centers if they come from a rural, area. And so at that well baby visit, is there development monitoring happening, right? Is there conversation that revolves around development? Is there, are there resources that the parent can access that will, trigger their thoughts towards development of this child? And then, of course, like I said, within the community, if you tend to pick up a baby with a problem, do they have access to a physiotherapy, center, or a occupational therapy, or whatever, whichever service that is required? Do they have access to these people in their community? If not, again, what is the process of them accessing these services is another thing, right? For example, a lot of Families come to us from very far away, and then they just come once a month or once in 2 months, and then we then make sure that we give them enough, what do you say, not just like one set of exercises or play strategies, but we offer them varieties or tweaks in some of these things as well. Like, okay, if your child is able to do this in 2 weeks, try changing, say, if your child is able to lift up this toy in 2 weeks, right? Try changing the toy, make it heavier, or try placing it 2 inches away, or some of these things. So you make sure that parents who are families who are coming to you, uh, who are sort of not accessible in that sense, are able to at least provide some kind of support to their infant at home. So these are, if you work in a NICU, I believe a lot of you might already be familiar with both these models of development. One on the right is the synaptive theory, which is, the autonomic motor and state regulation, basically defines if the child can attend, or interact with the environment. And this is what I was just talking about, having that safe space, having some of that postural support, some of the state modulations, the eat, sleep, poop kind of thing, that happens with maturation, neuro maturation. And so these are some of the things that we just have to have patience, for as the baby gets older, and we provide them, of course, with those supportive things that they will improve. In the NICU, this is what we do. In the one on the left is the NICU care model. As you can see, the center of all of this is the environment and the experience that they are getting. So, for example, for nutrition, right? Of course, we talk about breastfeeding, but not all babies go to the breast from day one. They might be on tube feeding. And so, how can we provide them with that healing environment during that process? So, just having the mother hold the baby in the breastfeeding position or during kangaroo care, so some of these things will help again normalize or provide somewhat of a normal experience or typical experience environment to the child. Any of these things, all of them lead towards again empowering parents and getting this child in a regulated state so that they are able to perform their ADLs. So at term age, it's just like I said, making sure that they're able to feed, maintain their temperature, have some of these spontaneous movements, engage with the what do you say, family, at that stage. So it might be a simple thing like that, but that is what they are required to do. I love this image. I think I have it in most of my talks because I feel like we really fail to see how the progression goes. Parents or lay people, and I am sorry to say, but sometimes even our medical team, the checklist that they use, or some of these things that they use, because the parents say that to them, that is what they take away. Are these end products, right? My child is not able to sit in class. My child is not able to, whatever, not repeat, the phone number, things like that. But these are very high level skills that do not magically begin at 3 or 4 years. If you haven't done any of these things that are, at the first, second, third level, it is going to be difficult for this child to achieve, all of these things that they are talking about. And so this is why early is important, early intervention is important, because you cannot have, if you're like building the tower, you cannot have a nice, strong tower without the foundation, right? And so all of these things, your posture, your, what do you say, balance, your motor planning, everything, builds up to what these skills are that are typically termed as, what do you say, or identified skills by parents, right? And I use a lot of this example, like, so for example, um, let me just look at the clock. I don't want to. Okay, we have some time. All right. So, one of the examples that I use to discuss this is hunger, right? So, an infant is hungry, they cry, right? A 1 year old is hungry, they will cry, but they will also kind of look at the kitchen maybe, or go into the kitchen. Or a 2 year old, they will point, they know exactly where the food is or something. A 4 or 5 year old will say verbally, will say that, all right, here, I want an apple. A 9 or 10 year old will basically go and grab an apple and wash it and eat it, right? If you are hungry, you actually cook a food, like cook and eat by yourself. And it's not just cooking at that moment, but you have planned in your head what is in the fridge, what is in your kitchen, how many people are going to eat. This person likes this. There's a whole lot of complex planning that has gone into, at the back of your mind before you actually cook something and then eat it, right? And so this is what happens because you have, enough exposure and enough experiences. This is what development is. And so, but to begin with, the baby has to recognize I'm hungry. And then when they are given food, that, okay, now I'm done, I'm full, right? And so similarly, all of these small things will add up to a more complex way of, being in life. Okay, so let's talk about development. I mean, monitoring. We have sort of three, it's a spectrum, all right? Everything is a spectrum. There are no, this is this, there's no demarcation where one kind of moves into the next. Monitoring is basically the whole process. However, surveillance is something that happens very informally. Like I said, my baby is doing this. Is that right? Is it, is this supposed to happen? Is it supposed to happen at this age? These kind of conversations with your pediatricians, or the pediatrician saying, hey, is your baby rolling yet? These are sort of surveillance type of things. Screening basically is use of a validated tool. We have a whole list of tools available. I would also say that, a lot of these are being used, but not over, what do you say, not routinely in every place. But again, very easy to give it to a family and, say that, here, why don't you go through these items and see what your baby is doing or is not doing at this point, and we can talk further. And then assessment, I think as therapists, a lot of us are very familiar with assessments. These are very standardized, tools, protocols that we use in order to identify percent of delay and then decide what, kind of services that we are going to provide. I just wanted to show this quick video. This is a surveillance visit at the high risk follow-up that I work at. So this is a 1 month old. Or not a 1 month old, I'm sorry, 6 weeks, because that's the vaccination visit. Okay. And so the pediatrician is asking, the neonatologist is asking, do you do tummy time? Now I have edited this video initially, so I'm just going to pause it for a second. The first half of the video says, does your child hold the neck up? And the mother says, yes, the baby does. And so the doctor asks, show me. And so she holds the baby at her shoulder and holds the back of the head, and kind of the baby's head doesn't wobble. So according to her, that's holding the head up. All right. And so now she's saying, do you do tummy time? Because that's something that we do at discharge. And now just watch how the mother is placing the baby in tummy time. Do you think this mother was confident? By the way, this is a term baby. This is not a preterm baby. We wanted to just demonstrate what typical would look like. Okay. So if you saw, right, the mother was very hesitant in placing the baby in tummy time. When the baby, was placed, the baby was not in alignment with, like it was, they were not in midline with each other. And so she turned the baby around. Also, I don't know if you noticed, but the hand on the other side was actually extended and not, in front to prop herself up. She also tested for torticollis. She turned the head on both sides, right? And then while she was doing the face to face engagement, she was also looking whether the baby is able to get the eyes into midline, or focus on where the sound's coming from. Clearly, we see no head turn response. Um, Another reason we had this video was to just show that some of these things to monitor development don't really add on to the time of the visit. This video was part of a workshop that we did for the Indian Academy of Pediatrics. Pediatricians were sensitized to some of these things that they can do in their OPDs. And so it was just to show that, it doesn't take more than 30, 40 seconds to add this development assessment or monitoring. So let me quickly talk about anticipatory guidance. Again, this is what is done before the occurrence of a milestone. Okay. So, what can the parents do today so that the baby gets their head control at 3 months? Okay. So, that is what anticipatory guidance is. A lot of these times, it is also, I mean, a lot of the times, anticipatory guidance can also be talking about use of screen, use of electronic toys, swaddling very tightly with the hips, extended. Some of these things that we know are sort of dangerous to, say the hip health, or will not contribute to development or the trajectory of development as well as they should. Over the last few years, I feel like mittens have become another thing that are constantly being used, and then we don't see the hand to mouth happening. And it's one of the early signs of hunger, right? And if the baby is not able to do that, eventually they stop doing it and they just start crying. And then that this is where the parent is unable to recognize some of the early cues for feeding, give them the response that they need without them dysregulating as much. And so, anticipatory guidance also talks about a lot of these things. We also discuss parenting myths or cultural myths, things like that. Parenting practices, a lot of times, again, in India, we have so many indigenous practices like bath time is, a lot of places it's sitting on the floor with the legs extended. That's the only place where they will put the baby in prone, for a brief few minutes or seconds. So things like that, right? And so anticipatory guidance involves all of these things. It You also kind of make sure that they are able to competently do all the things that you are discussing with them. What kind of suggestions for play? As physiotherapists, I believe a lot of you will recognize these are the principles of motor learning, right? The more fun, play-based, routine-based things that you do with a variety of sensory exposures and making sure that gravity is, is sort of also accepted in that sense, you're set. Stimulation. Okay, so this is a thing that I feel like we, as therapists are always your stimulation. So my question is, should you stimulate? Hmm? Stimulation usually means that you're providing something extra. And so I always, ask, are you doing what is routinely should happen? One of the most common things that I encounter is that babies are not placed on the floor anymore. They are constantly on the bed. And so, if this child is doing everything on the bed, that itself is going to pull them back, isn't it? If they are not exposed to gravity, if they are not exposed to getting that feedback from the ground that they need for, in prone, in tummy time, to roll, to, when they're reaching for an object and they drop their hand, things like that. Everything, their motor planning is basically skewed because they're on the bed all the time. And so, to me, a stimulation can simply be also just going to the floor. It doesn't always need to be adding, more fancy things, in that sense. Also, when, how much, all of this depends on the baby, right? We need to make sure that we are targeting the baby's capacity, not overwhelming them. And so, can the parent recognize signs of stress or overstimulation in that sense? Just because someone said do tummy time 4 times a day doesn't mean that your child is going to, get it immediately. And so, how do you gradually ramp it up? What are the other things that you can do in order to get to where you need to be? Okay. So, I will just show a quick video and then we will move to questions. So, this is what we do in terms of anticipatory guidance in our unit. As you can see, we, have the baby on the mother's chest in prone. Tummy, I am a big fan of tummy time. I feel like, babies need to go prone for us to like just get our basic strength and coordination and all that going. And so the earlier the better, calmer the better. So the baby is just on their mother's lap, and you saw how much movement they already had, right? This is another baby at 6 week vaccination visit. As you can see, the baby is going to slowly turn their head from one to the other side to the other. Again, you saw how much of body movements. This baby is a little older. Um, Actually, sorry, not older, a little younger. That baby was 6 week vaccination. I think this baby is like a month old, but that baby was preterm, and this baby is not. So you can see the difference. I love this video because it shows how the babies are already motor planning. Okay. Now we are in the ward, so obviously, like you can see, we are not on the floor, but see how the hand sort of adjusts to how far the baby is going to lift their head up. The first time they dropped their nose, they blocked their nose. The second time they were able to really, turn the head longer so that they could free it up. This is the 2.5 month vaccination visit. So you see the posture of the arms has changed, right? The baby is really getting their eyes involved. There was a lot of wobbliness. There it goes. There's a lot of wobbliness, right? But the baby is not dropping their head. Hmm? A little better with the vision and the head control. This is the 3.5 month visit. So I wanted to show this video because this is what anticipatory guidance does. When we talk about these things early on, when we encourage the families to play with their kids in a certain way. Now we just did the prone progression here, but we also do face-to-face engagement for the vision. We do a lot of the midline stuff. We do a lot of vestibular, talk about vestibular, what do you say, inputs, because the babies otherwise are just kept in one place. They're not moved, maybe just up to the shoulder for a birth, but then they're, back again in that horizontal. They really don't experience a lot of the vestibular, inputs that are required. And so a lot of this goes into then, getting a milestone like this at 3 months. Um, some of the other considerations, are again early referrals to other disciplines. So if you use something like the help chart or the mother child protection card that the Indian government has laid down, it gives you a nice guideline about what they should be doing in all disciplines and not just physiotherapy or motor. Same thing when you're suggesting play activities, right? So make sure you incorporate not just the motor bit, not just the fine motor bit, but engage, verbally as well, right? When you provide variety in, the toys or the activities, you're already targeting some of the cognitive, tasks as well. Especially for our high risk infants, I would really encourage all of us to think of early use of assistive devices. I feel like we don't do that early enough, and that pulls down some of the cognitive and the speech milestones that could naturally occur because the child is constantly on the floor and they're not engaged with the real world in the various dimensions, right? And if they're not upright, then some of that postural control for speech is also going to be missing. Even if they're not able to really vocalize, but just the communication, right? The idea of having that communication back and forth is different from when you're upright versus when you're lying down. And so I would really encourage therapists to start having this discussion soon enough. Using an assistive device does not take away from our goal of independence. You know, like we use vehicles, right? We use cars to go wherever we want to. Doesn't mean we always have to walk independently. So the assistive devices actually support our goals and towards independence than anything else. Providing parent support, like I just talked about, the whole range of mental health, I wouldn't call it concerns, but where they come from, there's a lot of baggage. And so supporting that, a lot of myth busting. I feel like there is, as in many cultures, there is a lot of, in our family, this is something that we do. But is that 1 hour of whatever you do with the child supporting development or taking away time from tummy time or something like that, right? So think of these things and then talk to the families accordingly. Um, so for me, I feel like monitoring, which is something that primarily happens in pediatricians' offices or primary healthcare centers, therapists can assess or assist in this process by providing this holistic, perspective. Especially if you are already working in an NICU setup where you've had some time to build some relationship with the family. I think we can provide anticipatory guidance based on our, again, the foundation of movement, so we know what kind of activities or what kind of play things can be incorporated into their routines for diapering or when they change the diaper, when they, feed the child, when they give a bath, massage, whatever it is, right? You can modify some of those engagements already to provide some of these experiences that the parents or the babies need. And lastly, I really encourage again therapists to speak up in team discussions. I feel like a lot of times we are not vocal enough, you know. I feel like that kind of also gives a lot of conflicting confusion, rising sort of, occasions for the families. Because if the doctor is saying something and you are saying something else, it kind of automatically raises that confusion in the family. So have a good rapport with the team that you are working with. Bring in your perspectives. I have had really good experiences with that, where the team does really engage in discussions about development on our level, on the functional level, and not just like the neurological. Where have you done the Hammersmith? Those kind of things. Like what beyond that, right? How do you discuss um, why early intervention is important if you're not able to put it across in a language that clicks with the family? And what clicks with the family's function at the end of the day, right? They want their child to do something, or they want to do something with their child, like together as a unit. And if that is not happening, they will look for help. So can we change our language in terms of function to sort of pull those parents into early intervention sooner than later? Okay, some of the references that I used. There are a lot more. This is a topic that is just widely, discussed, referenced, researched, because obviously we know that, the monitoring is where we are going to identify our, kids early. And the rates of disability, unfortunately, is not going down in spite of a lot of the programs being in place, a lot of awareness going up, a lot of medical, innovation that has come around. I feel like um, Nair sir's group, they had put out a paper. It is not recent. I think it's 2015, but the rates had not gone down in spite of all these, advances. So, yeah, these are just some of the references that I used. And so, thank you. I can see a lot of questions in the chat box. So let me just look at this. Does this level will be the same for children with autism? I do not know which slide this was for. This was Jyoti's question. I'm going to move to the next one. Jyoti, you can
No,
clarify, I
sorry,
guess.
sorry to interrupt, Pooja. She was talking about the levels of, where you start with sensory and then go to the next level of postural control, etc., and then go to
Yes,
level.
yes,
So yes,
yes,
so the
yes,
answer is yes, that these levels will be
yes,
for autism too. Yes.
yes.
Hmm.
That that image was from Jean Ayer's book. I feel like we should all read it. It is written in such an easy language, and it still holds true to date. So even though it's quite an old book, I think it was written in 70s, 75 or 79. Um, but yeah, it's still a very valid book.
The levels of development, basically, how the sensory systems develop as a base and then, progress towards more and more, higher level organization of everything else. Yes.
Yeah.
Mm.
Okay. Some of the literatures that says that tummy time may or may not be encouraged for term rather than preterm as it increases. Very good. I'm so happy someone asked this question, because when does SIDS occur? In sleep. Okay. When do we do tummy time? When baby's awake. I hope that answers that question. You do want tummy time. It's an awake play activity. The whole thing with the SIDS and the back to sleep campaign, actually, again, there's a ton of research on this. One of the references I had on my list also is a systematic review on tummy time. And you can see, in all the evidence that basically what happened is they said go to sleep on your back, but then they forgot to say what happens when the baby is awake, right? And so when some of the evidence started piling up that there's a lot of plagioccephaly, there was motor delays, all of these things, then they added another line on the bottom, said back to sleep and tummy to play. Okay. So tummy time is a play activity, a wake activity, adult engagement activity. It has nothing to do with SIDS. Suggestions about exact time and duration and age of the child. It starts at day one. You start at birth, okay? And you basically try to do about 5 minutes every diaper change. WHO says 60 minutes a day. I feel like if you say that, parents are not able to, at least here, I find parents don't understand what 60 minutes a day is. So I always say 5 minutes every diaper change. By the time the baby is about 2 months old, you do it 10 times, 10 minutes, 10 times a day. Okay. A little more than 60 minutes, but which assistive devices are commonly used? Well, it depends on the child, to be very honest. So the other day, I remember we had this infant who was close to 6 months and really without head control at all. And again, like I said, they were one of those families that were not regular, for therapy because of the distance. And so to me, I would have immediately discussed a chair for this child because they are going to start solids in a few weeks. At 6 months, again, you want to have a little bit of that off the floor posture for your vision, cognitive development, for your fine motor things. So I would have said something like a chair. But again, assistive devices, I feel like even giving walkers, early enough. But again, it depends on the child and the age and what they are, where they are. If they're just a few, weeks off, you think they're just so close to getting wherever they need to be, then you can wait. But for these kids who are very obviously going to need a lot of support, start sooner. Okay. Can you tell us about, sorry, I need my glasses. What age should we perform neurodevelopmental assessment? Um, So assessment will be something that you will get a referral for. So you might get a referral at 3 months, you might get it at 4 months, you might get it at 18 months. It depends on when you get the referral for an assessment. Now, an assessment is like a Bailey or a Dasi or a TIM, some of these standardized tools. For a screening, which is the ages and stages, or the MChat, they have ages. MChat is 16 to 18 months, which is the autism screen. I know there is an Indian one as well, but because I don't use it, I just blanked out on the name. The list is the language screener, again, India based. So the screening is when, so the 9 months, 18 months, and 2 years. I believe also 30 months somewhere I have read in one of the guidelines. So those are the standard this, but you can use a screening tool anytime. If a mother comes to you at 4 months and says, you know what, I'm worried about this, here's an ASQ. ASQ starts at zero, or not zero, sorry, 1 month, goes all the way to 5.5 years. So these are at your discretion. Okay. You can use them anytime. Criteria to consider as NICU grad: any baby that goes home from the NICU is a NICU grad. What would you suggest for vestibular inputs for infants? Okay, to me, again, just staying stationary in one place in the house is not enough. So even simple things like, moving the baby from one room to the other, tummy time, again, great. Walking with the baby. I always recommend, go out for a walk 2 times a day for 30 minutes each. And I encourage the fathers to do this because, again, if just say fathers engage, they don't know what to do. So if you give them a certain, what do you say, activity, they're more likely to do that. So, just, yeah, rocking, dancing. If you have a carrier, if the baby's in a carrier, you can move around, continue to do whatever you are doing in the house, fold your laundry, whatever it is, and that's good enough vestibular input for infants. um, Again, I feel like natural progression is better. So as they start rolling, as they start, in tummy time, right? At 3, 4 months, they're going to turn and look over their shoulder, things like that. They're already getting all the vestibular information that they need in a very routine-based, typical manner. Any insights on modern technology? I have no idea what that means, so I'm going to skip that question, please. Different books we can use for early intervention. I think that's what they are talking about. Um, I don't know. I feel like there are so many. I mean, I love motor control. I think that's the foundation of what I do. Shumway and Cook, Gene Ayers, like I said, the sensory, integration book. But apart from that, I don't know if I've used a textbook per se. Okay, I'm going to move on. Kid is 1.5 year old, no head control, tummy time. Well, then it is no longer called tummy time if the child is already 1.5 years old. Then you would do activities in prone basically. But tummy time is usually a play activity for infants before they achieve head control. Okay. Uh, Child is born with opisthotonous posture. What assistive technology will you recommend? Well, again, it depends on the age of the child and what function you're targeting. But chairs are great, right? If you can get a chair with a strap and a table in front of them, you might want to check how they do in that kind of a seated arrangement, so that they are able to engage with whatever is in front of them. Maybe the table is not too low, it's a little high, so that if they're already in that hyperextension, they don't have to get into too much of flexion, and um, get started with that and then see how you move on. There is one last question, and then I think we'll stop. In developmental delay with microcephaly, age 1.5 year old, miss milestones, how do you start? Uh, so very difficult. I mean, it's not a difficult question, but I feel like very difficult to answer without me knowing exactly what else is happening with this child, right? And so I feel like you have to look into what the family is already doing with this child. Are they expecting this baby to um, what do you say, so how, like, what do they see this child doing as part of the family, right? Maybe have meals together, right? Maybe go for a walk in the park, things like that. And if you can identify some of those experiences that the family as a whole is missing, I would begin there, because I feel like therapy is also quite a stressor. It is not something, I mean, I don't know how many of you actually work out, but I haven't done the same kind of exercise for more than like a year at a time, right? After a year, you get bored, you try something else, you try something, right? You know what I mean? So and we are asking these families to be in therapy for years on end. So I would, already this child is a year and a half and looks like there are some missing milestones. So I'm not taking away from them coming to therapy, definitely. But also, I would try to encourage you to have a conversation and see, as a family, are there some goals that you can set up that will, get some movement, get some, cognitive, say, engagement, something that is a little more positive
Yes.
with this baby.
And child is suffering with a bone infection, mean, ma'am, or
I didn't understand the question.
I think our questions are over. Thank you very much, and Puja. And Dr. Sektidas sir joined the meeting, and I request him to say a few words about this webinar. Dr. Sektidas sir. Sir, are you there? Dr. Shaktidas, sir. I think he left. Dr. Shaktidas, sir. Maybe he's busy with his patients and
No problem.
Dr. Shaktidas, sir. And Sandeep Samanta. May I request Dr. Saroj Jha to say a vote of thanks on behalf of Indian Academy. Dr. Saroj.
हाँ सर, हाँ पूजा 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 मैडम को इंडियन एकेडमी सेरेब्रल पाल्सी और तरफ से बहुत बहुत धन्यवाद देता हूं और आगे भी आशा करता हूं कि बेहतर प्रेजेंटेशन की उम्मीद करता हूं।
Thank you. Thank you, sir.
Thank you.